First of all, thanks to the organization for inviting me and for organizing this. I am Jeroen Luyten. I'm a health economist at the University of Leuven. And as mentioned, I'm a bit the odd one out today. My talk will be about financing of fertility treatments and how economic evaluation can contribute to the evidence base for making funding decisions. First of all, I have no conflicts of interest to declare. Well, as a starter, a bit of background. So what you see on this slide is that we, or at least our societies, are spending more and more money on healthcare. In absolute terms, costs are going up year after year, but also relatively speaking in terms of a proportion of our GDP. And that is to some a sort of an alarming trend, whereas it doesn't need to be that way, at least from an economic perspective. It doesn't need to be that way because it all depends on what do we get back for we spend a lot of resources on healthcare, but what we get back in return is also very valuable. So you see on the right-hand slide, you see the amount or the proportion of our GDP that we spend on luxuries and alcohol, tobacco, clothing, vehicles, and so on, restaurants, and you see that that is also a very big proportion. So, well, the question then is, as one health economist once said, famously, as we get older and richer, which is more valuable, a third car, yet another television, more clothing, or an extra year of life? And this is, of course, a rhetoric question. It's obvious that a year of life is, in terms of value proposition, hard to beat by any other way in which we can spend our money. But of course, we have to be certain that we get back something in return for our spending. So that is why more and more policymakers are asking for cost-effectiveness evidence, so that before we spend money on healthcare, that we know what we can expect in terms of health benefits for our spending. And that is particularly true if we look at it from the short term, where our health budgets are actually fixed. And so when we decide to spend more money on one treatment, for instance, a fertility treatment, then that means that there's less money available for other treatments, for other patients. So that is what we call an opportunity cost. And well, it's also from an ethical perspective, we need to be aware of that opportunity cost. So that is another argument why we should measure and compare costs and health outcomes in order to set rational priorities in the health budget. And interestingly, this is also, I mean, this is a logic from the government's perspective, but it's also the same logic can be applied to individuals and how they make decisions about how they spend their income in the short term or in the long term. And I think that is also important for the fertility treatment context, where patients often pay substantial sums from private resources. So, well, obviously, it's easier said than done to study to compare the cost effectiveness of competing health programs. Well, to actually make that feasible, governments have set up so-called health technology assessment bodies all over the world to do these studies to discuss cost effectiveness of health programs, of which you see a few on this slide. Now, how do we study cost effectiveness? We do that through economic evaluation. And an economic evaluation is a very specific type of evaluating healthcare. We compare two interventions. So for instance, a new program versus an old program, or a new program versus a do-nothing scenario. And we compare these two in terms of both their costs and their outcomes. And there's three separate techniques, which I will explain on the following slides: cost effectiveness analysis, cost utility analysis, and cost benefit analysis. And they are very similar in terms of the basic idea behind them. That is, we try to calculate an incremental cost effectiveness ratio, so-called ICER. And on this hypothetical example, that is supposed to be illustrative of how we calculate such an ICER when we have a program B versus a program A, and we know the costs and the effects of both programs. then we can see that program B is twice as expensive in total, but also twice as effective as program A. So based on that information, we can calculate an incremental cost effectiveness ratio, which would in this case amount to 35,000 euros of additional costs that we have to make per additional live bird that we would actually generate through implementing program B instead of program A. Of course, that's just a number. Well, we need to understand, is 35,000 euros per live bird, is that a lot of money or is that good value for money? To do that, we can use the so-called cost effectiveness plane, which you see here, and which allows us to judge whether an intervention is worth implementing. The easy part here is when we have an intervention that is both more costly and less effective than the alternative. So then we already know, well, we spend more money and we get less in return. We don't want that intervention. It's so-called a dominated intervention that should not be funded. And vice versa, if we have a program that has lower costs and better outcomes, also that is a no-brainer. We want that program. That makes economic sense to invest in it. The more difficult judgments are those where you have higher costs and also better effects. So, as in the example that I just illustrated, where we have we have to pay 35,000 euros more, but we also get more live birds. What we then need is some sort of a threshold that allows us to separate good value from bad value for money healthcare. So imagine that we know this magical number, and imagine that this is 20,000 euros per live bird, then that we actually know that well, in our example, which had an ICER of 35,000 euro per live bird, then we know that this is too expensive, so it would not be cost effective. Now, that sort of background logic applies to all techniques of economic evaluation. But there are important differences between these different techniques. So we have, in a cost effectiveness study, what we do is we calculate costs, but we compare these costs to an outcome measure of success expressed in physical natural units, such as in the case of ART, pregnancies achieved, live births, for instance, and that results in an ICER expressed in the form of a cost per effect. If we do a cost-utility analysis, then we have to express these health benefits in some sort of a generic unit of health called quality-adjusted life year. I don't know if you probably have heard about this before, where we try to measure the effect of healthcare in terms of survival, additional years of life that patients get, corrected for the quality of life in which they will live these additional years of life. And so, in that sense, we can express any type of healthcare, ranging from, say, cancer treatments to fertility treatments to diabetes care. We can all express that into a cost per quality, and we can compare these programs. Cost-benefit analysis is a similar technique, but then we try to monetize the outcomes, so the health benefits and also the benefits beyond health of a treatment. We translate these into monetary terms, and then we can make judgments in terms of for every euro that we invest in a program, how many euros in terms of value will we get back. Now, the most narrow technique is cost-effectiveness analysis, because of course we're limited to the particular outcome measure that we consider relevant. And the broadest form of economic evaluation is a cost-benefit analysis, where we express the outcome in money terms, and we can compare that money value to any other way we spend our money. Now, what should be driving the decision which analysis you should do? It's of course dependent on the question that we want to answer, and that depends on whose perspective we try to inform. And in ART, there are many stakeholders involved, and they all ask different questions. So if you provide economic evidence, then it has to be suited to the question that is being asked, depending on the stakeholder. So what could these questions be? For instance, a patient would probably ask the question, or I mean, in this case, a subfertile couple would probably ask the question, what is the least expensive path to a live birth? Or giving a certain willingness to pay for a pregnancy, which treatment should be chosen. If that is the question, then a cost-effectiveness analysis, for instance expressed as a cost per live birth, will provide the necessary information. A cost-benefit analysis, taking into account, for instance, patients' preferences for waiting and many other things, could also be informative to provide the patient really the information, the economic information needed to make a decision between different programs. A healthcare system has a similar but slightly different perspective. They will probably also want to know what is the least expensive way to give subfertile couples a live birth. But they might also wonder how can we improve population health in general, and what would the position of fertility treatment be in the whole scala of treatments available. And if we want to know these things, then we have to do a cost-utility analysis using QALYs, or we would have to use a cost-effectiveness analysis expressed as a cost per live birth, but then we would have to know that magical threshold value for a live birth. Society then has even more considerations that could be relevant. Well, in the first place, how can we improve social welfare, and is ART an important instrument for that goal? Or we can also ask how good an investment is MAR compared to other ways of spending our money, knowing that fertility treatments will actually lead to a new live birth, so a new person who would join the labor force, who would pay taxes, and who will be an economic factor in its own right. So, well, one aspect is to identify the stakeholder that we want to get informed through economic evaluation. Depending on that perspective, of course, different costs become relevant. And we typically distinguish between direct costs, which are the costs of treatment, the intervention cost, for instance, consultations and laboratory work. But we also have indirect costs, the costs of not being able to go to work because of sickness, for instance, or because of undergoing treatment. So the cost of foregone activities. On top of that, we have also patient costs, costs that are extra costs carried by patients themselves. And depending on whose perspective we try to inform, the cost effectiveness will be different, because different costs will become relevant for different stakeholders. Typically, for a patient perspective, we have to look at the costs that are actually carried by patients, so the user charges, the patient payments, in addition to some extra costs like costs of transport, out-of-pocket expenses, and so on. From a systems perspective, all the healthcare costs somehow linked to fertility treatments should in principle be relevant. For society, all costs should matter. Well, then another level of complexity is that, well, you can calculate an ICER, but we should always think what is the ultimate objective of that ICER. And there we have two different questions that you could ask, and two different ways of interpreting ICERs as well. We could be interested in questions of technical efficiency. And there, the problem is, we have a clear objective of what we want to realize. And so we want to know what is the cheapest way of doing that. So, for instance, if we know we want to create a live birth, what would be the cheapest way to create a live birth? Or, from the government perspective, we have a ring-fenced budget specifically for fertility treatments. Which treatments should we then fund with that money in order to maximize the number of live births in a population? So if that is our objective, to inform on the level of technical efficiency, then cost-effectiveness analysis will do the job. If, however, we are interested in questions of allocative efficiency, which is much more complicated, then we want to know how much we should invest in something compared to available alternatives. And that is the question that we want to ask if we don't have a fixed budget, or at least we have a budget, but the thresholds or the size of the budget is open for debate. For instance, within a broader healthcare budget of health insurance, for instance, what is the share that should be going to fertility treatments relative to other disease areas? Or also in terms of interpretation of patients, patients might want to know the technical efficiency question, what is the cheapest way to get a live birth, but maybe they also have flexible budgets and they just want to know, they want to spend more money on one treatment versus another, knowing that the cost per live birth will be higher, but just because they think that in the end this is worth the resource. So they have all things considered, all the ways they can spend their money, they think that an additional X amount of euros is worth the cost to get a higher chance of getting a live birth. So these are questions of allocative efficiency. They are more complicated. And to answer these, we actually need cost-utility analysis or cost-benefit analysis or cost-effectiveness analysis, as I will explain, but more in a more limited manner. Now, that's the theory behind economic evaluation. Very shortly, how is this been used in practice in the field of fertility treatments? We see that there is overall an increased interest in this area. So there's more and more publications on cost effectiveness of medically assisted reproduction. And we are currently in the process of doing a systematic review on this subject. Over the last decade, we've seen that there were 83 studies published reporting an ICER of a MAR program, and we see that the large majority, 95% of studies, are cost-effectiveness studies. So very rarely do people do cost-per-quality analysis or cost-benefit analysis. Mostly it's cost-effectiveness studies, and half of all studies are expressed as a cost per live birth. And then 25% is expressed as a cost per pregnancy, more or less. And 60% of these studies are executed from the health system perspective. So a perspective where we have the healthcare provider trying to estimate what would be the most cost-effective way of treating a certain patient population, but disregarding various patient costs, disregarding productivity costs, and many other aspects. Cost per live birth is indeed a very straightforward metric to express the cost-effectiveness of MAR, and it has as a benefit to cost per pregnancy achieved that you can take into account misconceptions. And it is also very useful to express to patients something that is perhaps more difficult to understand, that you can have a treatment which is more expensive per cycle, for instance, but that is actually also more effective. So if you then want to, well, if there's a sort of a risk that people would focus on the cost side only, and then they would see that the more expensive, that one treatment is more expensive than the other. But an economically wise decision always compares costs to outcomes. So a cost per live birth could signal to patients or to policymakers that it's actually better value for money to invest in the costlier treatment than in a cheaper treatment, because you also get better health effects. In principle, such an analysis, cost per live birth, can also say something about allocative efficiency, but like we've seen on a few slides earlier, we need to know the threshold value of how valuable a live birth is to be able to judge whether we should increase our spending on that area. So to make these broader judgments of allocative efficiency, we need cost per quality analysis. And that will be able to tell policymakers, all things considered, how valuable fertility treatments are in the whole range of possible interventions. So how much health, in general terms, can we buy by investing in MAR? And well, as you see here, it's already very dated, this graph, but we spent very small fraction of our resources on fertility treatment, and we spend a lot of money on, for instance, mental health care or strokes and heart attacks and so on. So the question then is that justified, and on what basis do we allocate these budgets? To judge these things, we need something like a cost per quality analysis, which we could be able to illustrate the relative efficiency of, say, cancer treatment to fertility treatment. Of course, the big difficulty here is that you have to know which qualities to count. And well, obviously, we can count the qualities of the parents. These will increase because of the reduction in the fertility problem will be solved, and so that is in itself something very valuable. So the qualities of mother and father need to be counted. But what about the qualities of the newborn child? That is a very fundamental question, and that is what really distinguishes assisted reproduction from other fields, is that we really create a new human being. And that makes a dramatic difference, as you see on this figure. It makes a dramatic difference in cost effectiveness if we count the qualities of the newborn child, or if we only focus on the parental qualities. And well, we've also investigated this issue in broader terms, where there's many interventions that affect future lives. Well, it's not easy to make a judgment there, because if we say that the qualities of the child don't count, then, well, we actually say that there's no value whatsoever in that creating a new life, which is clearly wrong. On the other hand, if we do include these qualities, that would make fertility treatments among the most cost-effective programs ever, because you would add 60, 70 qualities to the parental qualities. Some researchers have therefore, because of these problems with the quality, they have therefore argued that cost-benefit analysis would be a good strategy to estimate the broader cost-effectiveness of assisted reproduction technologies. And that could be true, but it's in fact the same problem also pops up in cost-benefit analysis. We need to know what are the outcomes that need to be monetized. And so what we see in literature is that researchers then often only focus on a very small subset of consequences. They ask parents the willingness to pay for a newborn child. But that is in fact a monetization of the parental benefit. Again, it's not saying anything about the broader long-term consequences of putting a new human being in the population. So these analyses are always partial evaluations. I've never seen a full evaluation. Of course, that brings us to a key question here. If we want to know, well, the answer to the broader question, what is the value for money of assisted reproduction technologies, we need to understand what is the dollar value of the monetary value of a new child. And there's many techniques that could be used in this respect, but they're completely different conceptually, and also they lead to completely different estimates, as you see here on this slide. So this is, I think, an area that where we need conceptual clarity, and we need more research to really fully understand cost effectiveness in the context of fertility treatment. This is one example that did try to look at the longer-term cost effectiveness of fertility treatment, where these researchers looked at the amount of money that the state has to spend on paying for fertility treatment, and how much tax revenue they would actually get back over time, and then discounted, of course, but how the revenues through taxes compare to the expenses in terms of treatment costs. But again, this is only focusing then on tax revenues, excluding many other costs and effects in the long term of putting a new human being on the world. As a final slide, so if we look at the full spectrum of costs and effects that could be relevant in the context of ART, then we see that there is a very broad range of costs that could be relevant. So the cost of diagnosis, cost of MAR itself, cost of pregnancy and complications, the cost of delivery, then postnatal follow-up care. Later on, you have to take basic cost of basic childcare, complicated childcare. Later on, that child will also become a labor factor, so to speak, will start working and contributing to the economy and so on. So we can really go on very far in terms of thinking about cost implications of fertility treatments. And we can do the same thing on the effect side as well, where we can look at short-term effects on parents, the well-being because of people being helped with their fertility treatment, fertility problem, for instance. But also in the long term, having children will have effects on parents, and as well, like not having children will also have effect on parents in the long term. And then we have the child itself, and so on. So there's many, many benefits that could, in principle, be compared, or could be measured, and that need to be compared to costs if you really want to understand the cost effectiveness of reproductive technologies. But what is typically done in the literature is that researchers only look at some very short-term costs, and then they compare that to a very limited effect outcome. Okay, so in conclusion, economic evaluation is done because we want to inform decision makers, governments, or patients in terms of the value for money or the cost effectiveness, the efficiency of the healthcare that they want to buy. So in order to enable them to make economically informed decisions on what they get back in terms of the expenses they incur. And that is done in any medical field, but in the context of reproductive technologies, this raises many specific questions because it's a very unique intervention where you create a new person. So there's many challenges, and it's important to know that there's many techniques, so different techniques, and they can all be executed from a different perspective, taking into account different costs and also taking into account different outcomes, making it very easy to start comparing apples with oranges if you just look at ICERs without thinking about these nuances. What we see in the literature, the typical way to do this is looking at cost per live birth, and that is very informative to patients and also policymakers, particularly if they are interested in the technical efficiency question, what is the cheapest way to achieve a live birth. But for the equally important, perhaps even more important question of allocative efficiency, we need to know more than that, and we need to have a broader perspective, taking into account all these broader costs and effects that are relevant or that are related to medically assisted reproduction. Okay, thank you very much.
And I have some questions from the floor already. I think being such an interesting topic, people is quite curious about some of the things you mentioned. First thing is just a comment rather than a question. It's anonymous, but it says, totally agree. Infertility treatments should be considered as the most cost-effective due to a new child is born, and no ambiguity should be expressed about this. So I guess this relates to the tax reimbursement. I mean, value for money. You pay for the IVF cycle, you have a new baby, and this baby is going to pay taxes to pay for himself, right, or herself.
Yeah.
So those calculations have been made already, right?
Yes. So indeed, well, it's true. Like I think if but we need to know more about these issues because they haven't been investigated sufficiently. But intuitively, I would say that yes, indeed, it's hard to beat the value created by fertility treatments because you create a new person, really. So that's very hard to beat. But it raises many ethical questions, I think, in terms of, is that the same thing, creating health instead of restoring health from patients? So there's many people thinking that this should not be, that we shouldn't count these qualities in the same way. So It's a very profound ethical question, I think, but I do think that at least from a policymaker's perspective, maybe not from patient's perspective, but policymakers should be thinking about these things, that fertility treatment is, on the one hand, it's a healthcare intervention, but on the other hand, it's also an economic decision to, purely economically thinking then in terms of in terms of adding someone to the labor force, for instance, or that will, these tax revenue considerations become relevant for the purely economic question. It's not a healthcare question anymore then.
But I think it's a very interesting point. We were actually discussing this with Professor Fatemi at lunchtime and with some people from Sorono. And this paper that you showed by Bill Ledger from Sheffield, and there's some others from years ago, I think it's probably a very convincing way for politicians, because otherwise the discussion becomes very philosophical, and they are usually very down to numbers. So I think this self-funding of paying for my treatment when I'm a baby, because I will pay back with my taxes, could be quite convincing. But just provoking. There's more questions here. Dr. Tanya Milakic, again, is quite active today. Is there a difference between cost effectiveness per live birth rate between East and West European countries?
Between which countries?
Eastern Europe and West Europe?
Well, I don't know. No, I don't know the answer to that. I think could be, of course, depending on the costs incurred in, well, the relative countries. Of course, costs are depending on the health system. So if we have a different health system in these countries, then obviously the costs will be different as well. And it depends on the perspective as well. If, for instance, in like where I'm from in Belgium, fertility treatment is well subsidized, but in other countries it might not be, and then you would have to look at different perspectives, and then patient perspectives become much more important.
There's another question. I guess we as clinicians always think about immediate outcome and patient health, of course. The question is how to differentiate cost effectiveness, as you mentioned, for health risk in the case of optimal number of oocytes and the risk of complications like OHSS, like hyperstimulation. How you balance that?
Yeah. Well, yeah, that's a very good question, I think, and it depends on the choice of outcome measure that we use. So if we, depending on the metric that in which we're going to express cost effectiveness, we will automatically ignore certain elements. So these, like complications, for instance, could be excluded if you look at a cost per pregnancy, for instance. Then I think then you would probably ignore complications that would occur after a pregnancy. If you look at a cost per live birth, then you could include these. But then, of course, these additional costs will sort of work in the disadvantage of the more effective program, because you have a higher risk of getting complications if you get more live births. So in that sense, it's important to identify who's the stakeholder that you try to inform, and what is his objective. So if it's really a very specific earmarked budget for fertility treatment, then you could exclude certain healthcare costs because they're sort of not directly relevant for the objective to maximize live births, for instance. Yeah.
There's another question regarding, I guess, is the way you analyze the way you assess the quality. Should health economic studies with ART use the generic QALYs that you mentioned in the analysis, or adapt more to customized quality of life assessments like the FertiQOL? FertiQOL is one of these questionnaires used by psychologists.
Well, that's, I think, a good research suggestion. So, well, of course, how you calculate quality depends on how you define quality of life. And if you define quality of life in a way that doesn't really include the problems of infertility, then you will underestimate the quality of life impact. Or, well, what we typically use is the EQ5D, which is a very rough measure of quality of life. It does include a depression and anxiety dimension. So indirectly, I guess, infertility problems would feed into that in the longer term. But of course, if you really want to be sensitive towards fertility problems in themselves, then a thing like the FertiQOL would be much more accurate. And that's a good suggestion to try to link that to the calculation of QALYs. I don't think that's been done before. So.
Okay, so one question from Dr. Badwala in the room. As health tourism or cross-border reproduction increases, the differences in practice, for instance, selective single embryo transfer and associated multiple pregnancies make it difficult to measure indirect cost, I guess. So how do you take that into consideration, cross-border reproduction, and say a patient from the UK goes to other country and she comes back with a twin pregnancy?
Yeah. Yeah, exactly. Then the same thing. It's depending on from whose perspective we try to understand cost effectiveness. So if it's from the domestic budget and well, it's the cross-border healthcare is financed outside of the country, then this complicates matters because then it becomes a cost outside of the scope of the stakeholder, whereas the complications would probably come back within the country, would become relevant. So these things are cases that haven't been, examples that haven't been investigated properly, I think. But in general, what you want to include is all the costs that are falling on the stakeholder need to be included in the cost effectiveness estimate. So, well, cross-border care is in that sense, depending on how it's arranged across nations, who pays for what.
Mm-hmm. Please, Dr. Fatemi.
First of all, congratulations to the very nice presentation. I have one comment and one question. The comment is when you say third car and 1 year, you have to define which car. So that's my comment. The question, I remember when I was a junior doctor working in geriatric departments, intensive care units and surgical units and so on. We were doing everything to keep people alive, even though they were terminal. We were doing a lot of expensive tests and we were trying to keep them alive as long as possible. So now we are calculating the cost for a live birth. Are the calculations looking on the other side? How much money we are spending on the other side on elderly people and how far we go to keep them alive? Because at the end you have clearly demonstrated this child which is born is going to pay for him or herself at some point in life. On the other side of the graph, do we have data on that, how far we should go to keep people alive?
Well, that is indeed, researchers investigate this end-of-life care and the cost effectiveness of that. And that's one of an ethically sensitive matter, obviously. But I think it's in this sense that should be an argument if we do these analysis, we calculate the addition, like the quality gains that people get at the end of life and the costs that need to be incurred for that. If we do that, then there shouldn't be a problem to do the same thing in the context of fertility treatment. But there's not so many people who've tried to do that. Of course, it's complicated, but shouldn't keep us from doing that, I think. Because indeed, that's a valid discussion. Well, how much... But that requires cost per quality analysis again. Huh? So in most studies in the field of fertility treatment are cost per live birth studies. So as long as we do that, then we don't engage with that discussion.
Sorry, thank you. I enjoyed your talk, and indeed the cost from UK was an estimate of a live birth, £109,000 sterling from Mark Connolly. But just to mention, this is a very difficult area, and you have to remember we're not talking about one patient. We're not talking about two patients. We're talking about three patients here. We're talking about the woman, you're talking about the man, the quality of life individually and the quality of life together, and also the child. Mm-hmm. So when you do the cost analysis, it's probably one of the most economically effective way to create voters. And this also is part of the calculation, because the political establishment will always listen to somebody that says, don't you want to be the political party that creates life? Just to draw the attention that in any calculation you make, as was already said, somebody dying, somebody having cancer, so on, there's one single patient. Here, from the beginning, ab initio, there are two patients individually, but also combined as a relationship. Yeah. Yeah. And then the child to come in. So I would reckon that if you take the discussion from that perspective, the cost benefit will be absolutely phenomenal. Thank you.
And any other questions from the floor? Because yes, please, Dr. De Hoop.
Thanks, Professor Luyten. I think one way or another, as a community, I mean, as a community of reproductive medicine specialists, we will need to solve the challenge with equality, right? Because that is, in terms of health economic language, health economic speak, one of the very important determinants on how budgets are allocated within healthcare and even on a societal level. So it means, and as mentioned by Professor Morcano, this is a challenge given the fact that there are multiple people involved, but we need to solve this, right? We need to solve this in a credible way that decision makers will adopt and approve our solution. How do we do that? Ultimately, how do we translate the concept of quality to fertility in a way that it can position rightly? I mean, I refer to countries like China and others, have really increased budgets to have more children in view of a very low natural birth rate. So societies are already increasingly stimulating / allocating budgets to achieve that. Whether that's based on quality or not, probably not. But yeah, I just wonder what is the next step really, because I believe as a profession, as a biomedical group caring for a specific patient population, we have neglected this. We are lagging behind so far in our health economic excellence and maturity and ability to speak convincingly at the levels where we need to speak, where the money is essentially.
Yeah. No, I think it's a very good point. So first of all, I think we need studies just documenting, like the study from Connolly, for instance, focusing on the tax revenues, but I think there's other methods as well, purely trying to illustrate the economic sense, disregarding health benefits, purely the economic side, the financial side of what comes back for every euro you invest in fertility treatment. There's not so many studies doing that, but that's one step to speak to policymakers, I think. But then it becomes a purely economic problem. It's also, like you say, a health care problem. Like, what is the health impact? Also, the comment earlier made. Infertility translates into many ways into human health, through mental health, through all kinds of effects in the very long term. That makes it a health problem. So, to really engage with policymakers in the health care area, indeed, I think qualis are the key to get into that field, or to get into these discussions. And well, we would need more studies doing that. So documenting the impact in terms of extended years of life for people having children versus people who stay involuntarily childless, effects in terms of avoided depressions, avoided other problems that I'm not a specialist in that, but I can assume that there's many other problems linked to the fact that somebody wants to have children and cannot have children. So all these social, psychological effects that translate in the long term into health effects, we would need to measure these over the lifetime of couples, and also the relationship between partners itself, links with stable relationships and how that translates into health effects itself. So we need to understand much better what the quality impact is of solving parental infertility problems. And then on top of that, like we said before, we need to decide on the really profound, almost philosophical question on what to do with how valuable is the fact that we put a new person on the world who will enjoy life itself. So that is a question in its own right. And you can say, well, purely conservatively, we're not looking at these qualities of the child, but that is not very consistent, because in the same way you can also, this is not a discussion that is unique to fertility treatment, it's also applicable to genetic screening, for instance, where we have to calculate the value of not having particular people being born in a particular disease, or with a particular disease, a terrible genetic disease, for instance. So how do we value the fact that somebody does not come into existence? These are very, very difficult questions, but I think we do need to engage with that to really speak to policymakers in terms of what is the economic value of medically assisted reproduction, but also the healthcare value of it in that whole debate of how to prioritize resources.
Okay, so just one final comment, and I think we need more people like you in this type of meetings and our daily activity. I don't know, but when we talk about health economic evaluation, we tend to think about very macro level and policymakers and regulatory agencies, but then it comes down to our daily activity and how we see our profession in the next 5 or 10 or 20 years. But also it comes to down-to-earth questions. And Dr. Alex was mentioned this morning, for instance, in the room, he's from Switzerland. He was asking, what about natural cycle versus HRT cycle? Is more expensive or less expensive? So maybe with teams like yours, we can estimate if a natural cycle, even if it requires more scans, because it prevents maybe prematurity or preeclampsia, we can make it cheaper than HRT. I don't know, these type of things, I think, should be discussed. So thank you very much.
Okay, thank you.
Thank you.